Gopinathan sir, good evening. Muruganandam, good evening.
Today with us our President Dr. Ramas and Dr. Joshi sir, ex-President Dr. Ramas sir, welcome sir. And I also welcome Dr. Joseph Matthew sir, our coordinator, Madam.
Recording in progress.
Good evening, sir.
I also welcome our session expert, Dr. Kanana.
Boss live పోయచ్చు.
Thank you, boss. கோபி தானே? நர்மதா யாருக்கு கொடுக்கணும்? ஹோஸ்ட் யாருக்கு கொடுக்கணும்? இல்ல வேற ஸ்லைட்ஸ் யாரும் பிரசன்ட் பண்ணல. நந்தா, யூ ஆர் நாட் கோயிங் டு பிரசன்ட் இல்ல? நந்தா சார்
என்ன சொல்லுங்க சோம்ஸ்.
இல்ல நீங்க ரீட் பண்ண தானே போறீங்க. ஸ்லைட் பிரசன்டேஷன் இல்ல உங்களுக்கு?
எனக்கு ஒண்ணும் இல்ல.
சரி, ஓகே ரைட். அப்ப நேரா கோபிக்கே கொடுத்துடலாம்.
Good evening, sir. Somasundram, sir. Good evening.
மேடம், குட் ஈவினிங் மேடம். வெல்கம்
evening,
மேடம். வெல்கம் நந்தினி
sir.
மேடம்.
சரிங்க sir.
வாங்க மேடம்.
சரிங்க sir.
Good evening.
Good evening, Jalil. Good evening. Good evening to all the teachers.
Good evening, ma'am.
Good evening, Narmo.
Good evening.
Good evening, ma'am. Start பண்ணிடலாம் மாமா.
Murugan boss, good evening.
20.
Can we start?
ஆமா, கரெக்டா இருக்கும். ஒரு 5 மினிட்ஸ்ல இது போச்சுன்னா கரெக்டா இருக்கும். Yeah.
Okay. A very warm good evening to all of you who have joined on the platform here. Today we have yet another session of Wednesday, and we are moving from black and white to the other sector. Now I request Dr. Rajkumar sir to start this session with the pediatrician's prayer.
Thank you, Narmada. Pediatrician prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love, peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good, and accept within reason the things we cannot change. Grant us your blessings, grace, and mercy in all situations, at all times, amid all people. Thank you. Over to you, Narmada.
Thank you, Rajkumar sir. Now I request Dr. Somasundram, our President, Indian Academy of Pediatric, Tamil Nadu State Chapter, to say a few words and start the session.
Thank you. So, respected dignitaries on this platform, my TNSC team, Secretary Dr. Narmada, Treasurer Dr. Rajkumar, our academic coordinator Dr. T.N. Manohar, and the convener and the coordinators of this Wow Wednesday series, Dr. Thangavelu sir, Dr. Nandakumar, and Dr. Shri Priya. So we have crossed a few sessions, and 6 sessions has already been completed, with the 5 concentrating on X-ray, the last one concentrating on ultrasonogram, and now it is the advanced one, which is the turn for the CT and MRI. So this is the penultimate session, and we will be closing this black and white Wednesday, white and black Wednesdays by the next Wednesday. And we are completely tuned up for the next Wow Wednesday series, which is the Wealthy Wednesday, which will be launched on the 1st of April, which is on Wednesday. So for this session, we have the none other than our radiologist of the town, Dr. K. Gopinathan, who is a good friend of all of us, known by his popularity in diagnosing MRIs, and who is with the radiology department of the government medical college. And to moderate this session, we have Dr. Rams. So I think he's with the Trichy Medical College, and with the professor of pediatrics at Trichy Medical College. So hope this will be a learning session, and I believe Dr. Gopinath has come up with a novel way of teaching CT and MRIs this time, and this will be completely beneficial for those people who are there on this platform and who will be viewing this in the YouTube at a later time also. So happy learning radiology, and we will see. We'll have the lecture series from Dr. Gopinathan. Before I'll ask our academic coordinator, Dr. T.N. Manohar, to say a few words. Thank you.
Yeah. Good evening, all. My dear friends, we have learned radiology image from various lectures for the past 6 weeks, and this is the 7th week. We now know how to interpret radiology images using their difference in density, the outline, and alteration in shape. And now today we are going to learn how to interpret CT by using their alteration in density, and also MRI basics, how the alteration in intensities will give various pathologies. To teach us, we have with us Dr. K. Gopinathan, professor and head of the Department of Radiology at Government Kilpauk Medical College Hospital, and he is a renowned radiologist of the country. And to chair this session, we have with us Professor Dr. Ramasubramaniam, Professor of Pediatrics at Government KAP Medical College at Trichy. It will be great learning for us today, and our sincere thanks and appreciations to Dr. Sri Priya, Dr. Nandakumar, and Dr. Thangaveli sir for their efforts in organizing this CMA series of radiology. Now over to you, Dr. Narmada and Dr. Sri.
Thank you so much, Dr. Manohar sir. Yeah, indeed, it was a very nice lectures we had, and now we are going to move into a very interesting field of CT and MRI. I request our coordinator, Dr. Nandakumar sir, to introduce the chairperson and take over the session from here.
Good evening. To introduce my good friend, Dr. Ramasubramaniam. He is at present working as professor of pediatrics in KIP Medical College. He's the undergraduate of Madurai Medical College and is a postgraduate of ICH Egmore. He has a clinical experience, teaching experience of more than 18 years, and he has 4 journal credits in his name. And he has also received the Active Pediatrician Award in the year 2023. I welcome Dr. Ramasubramaniam to share today's session. Over to Dr. Ramasubramaniam. Dr. Ramasubramaniam.
Good evening, all. At the outset, I thank the IAP office bearers, Dr. Somasaram and Dr. Nandakumar, for those nice words. I'm happy to chair this session, 7th session of this Wow Wednesday series, which has received a very good response, one of the flagship programs of the IAP Presidential Action Plan. And I'm happy to introduce Dr. Gopinathan. Sir is a professor and head of the Department of Radiodiagnosis at Kilpauk Medical College, Chennai. And he's also a consultant in KKCTH, and he's a consultant in Scans World. And sir's area of interest is in image-guided interventions, especially in pediatric neurology. He has more than 20 publications to his credit and has given more than 200 guest lectures. And he has authored 3 chapters in pediatric neurology, pediatric clinical neuroradiology books. So he's a right person to enlighten us about the CT and MRI, the basics of MRI today. And we are eager to hear from Dr. Gopinathan sir. Over to the speaker, Dr. Gopinathan sir.
Thank you, sir, for the nice introduction. We will go into I think this is the first time I am trying the Kahoot presentation in the online interactive session. I think this, the thing is, first of all, so everybody's talked about the black and white. So in radiology, if you think about black and white, it's nothing. So we are always talking about the shades of gray. Okay. So not the 50 shades of gray. It's what we are talking about, the shades of gray, whether it's a light gray or a dark gray. So if you're looking at the black and white means, so black means, so everything, if you're looking at the X-ray means it's air. And if you are thinking at the white means you are thinking about the bones. So what we are interested about the soft tissues. So soft tissues will have the gray. So my talk is mainly about the shades of gray. Okay. So at this time I am trying the Kahoot platform. So those who are in the Zoom meeting, they can open their phone, and there will be a game ID will be there. And also if there is a QR code also there, you can enter the QR code or the game ID. You can participate in the interactive game. So I think it's a novel way of interactive teaching method, so that the both the presenter actively engaged, and also the all the participants so actively engaged can learn more effective way. So I am trying this is the new first time. So any problem, any small difficulties, please pardon me. So we will go into the session. Are you able to see the screen?
Yeah, Gopi, it's seen.
Yes, sir.
Yeah.
Yes.
Yeah.
I think I have opened the Kahoot. This is first for the CT chest imaging. So the Kahoot number is 693-473. 693-473. You open the Kahoot IT app. In that, you put the I want more people participation.
So everybody first should download the Kahoot app, right?
So no need to download the app. Just you
Okay.
Put the www.kahoot.it.
Okay.
To Kahoot ID, you to play the Kahoot. Okay, you just play the Kahoot, so it will open. So no need to download and everything.
Okay. Got
Just
it.
to go to the website, it will open. So go to the Kahoot IT or Kahoot app. Just can click the QR code. Can get in, or else you can go into type the 693-473. Shall we start, sir?
Yeah, you can go ahead, Gopi.
Okay,
Yeah.
okay. So if anyone want to join in between also, we can join with this number. Okay.
Can we put this in the chat box? It will be useful.
Yes, yes.
Will that be?
Yes, sir. Yes, sir. Anyone can put that in the chat box, sir. Okay.
Yeah, what I will do, I will take a screenshot and then do that.
Yes, sir. Yes, sir. Yes, sir.
Okay. Yeah.
Okay, sir. I am going to start the game. Okay. I am starting. Okay. First of all, I thank IAP for giving me this opportunity. So we will go into the chest imaging, but basically CT-based imaging. We are talking about mainly when we have to do the CT, and also what are the important diseases we are going to cover. So here you can see the first thing. First is a demo. So where are you now, sir? Some people may be in the hospital, some people in a home, some people at a cafe, some people at maybe relaxing in the park. Just say 20 seconds. Okay. So great. I think everybody is at their own respective place. Okay, we will respect their our place. Okay, we'll go to the next thing. Okay. So least radiation technique in the chest radiological investigation. Yes, exactly. The MRI is it's a non-radiation technique. Okay. All the other things, radiograph, nuclear medicines, and CT, everything is a radiation induced radiation techniques. So you have to careful in dealing with this radiation induced techniques. Okay. 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 So someone has to get the point, you have to answer very quickly. So based on the quick, the answer will change, and the points will change. Okay. So coming to the chest imaging modalities, you know that radiograph and the computer tomography and nuclear medicine, MR and ultrasounds are there. And because the lung having the lot of air content, you will have the inherent contrast is there. So lung tissues will have a parenchyma will have a dark appearance, whereas the interstitium or the lung vessels will have a bright. And that's why for the lung imaging, the CT is the best one thing. And if the lung is not having the protons, so since it is having filled with the air, it doesn't have protons, it doesn't create any MR signals. That's why the MR is not that much useful in the lung imaging. But now the recent advance in the MR will also show some kind of interstitial pattern very clearly. You can use it for the follow-up of the some already CT diagnosed patients. Okay. As you know, the nuclear medicine usefulness, and also the ultrasound. Ultrasound, you know that the fluid and the peripheral consolidation easily it can be differentiated. So coming to the CT chest, so we have moved from the conventional CT to the spiral CT. So conventional CT, what we take the single slice we will take, and then patient move, we'll do the second slice. We won't get the volume here. Nowadays, we are getting the 3D volume acquisition. The patient is moving while scanning the patients. So patient is moving in the gantry while taking the scan. So we are getting the this kind of spiral volume. With this spiral volume, we can reconstruct it in any form so that we can do the sagittal, coronal, everything in clear as you seen in the MR. So next level, so this thing spiral single slice spiral CT nowadays became a multi-slice. So multi-slice, it can be a 4 slice, it can be a 32 slice, it can be a 160 slice, it can be a 360. So if it means that if you are seeing here, so there are multiple slices. If you are seeing the multiple row of detectors from here to here, single exposure, we can cover the largest portion of the chest. That is the single exposure, we can finish the chest CT also. So that's why the multi-detector CT, the increase in the number of detector is there. So we can image the even scan, even finish the scan in single second or 2 seconds itself. So any crying patients, uncooperative patients, that is easily we can be taken with the high multi-slice CT detectors. Okay, that is the advance. Since for so usefulness of multi-detector CT, we know that. So what are the thing? Can answer? Yes. So if you're looking at the reduced movement artifact, so for that only we are doing the multi-detector CT, and also we can do the virtual endoscopy with this machine. And the only thing is the soft tissue characterization. Since the CT doesn't have that kind of soft tissue differentiation, it cannot differentiate isodense lesions, that is a muscle lesions, whatever thing. So it's very difficult. The MRI is the one we can do the best soft tissue characterization. And also the multi-detector CTs can, with this multi-detector CT, we can reduce the scan time. So the most of us given as a virtual endoscopy. So virtual endoscopy only what we are seeing in the CT scan. Okay. Okay. The Haran is leading the board. Okay. So as you know, as I told, it's a multi-detector CT, first generation, second generation. Nowadays, 64, 128 is there. And next final thing will be the proton counting. Photon counting CT means, I think with the photon counting CT, we can reduce the timings. Okay. And without any cardiac beats, we can do the cardiac CT, the photon counting CT. And also all the structure will be very crystal clear in photon counting CT. That is way forward to the after the after the 360 slice CT. The photon counting CT is not yet available in Chennai. In some of the centers having the photon counting CT is available. Okay. So the usefulness of multi-detector CT, it can reduce the scan time, it can reduce the motion artifact, it can take a multiple force in a quick session, that's arterial phase, portal phase, and also you can take the tissue perfusion. Since it is isotropic resolution, we can do anything, sagittal, coronal, any sections we can do. And also we can do the angiography and also the virtual endoscopy. We can do the virtual endoscopy of the lumens, we can do the virtual angioscopy through the arterial lumen, and also we can do the organ perfusions also with this multi-detector CT. And also here, this is organ dual energy CT is there. So here the basic principle is the same tissue is exposed to the two sets of X-rays. That is, one is low energy, that is kVp, 100 kVp, other is high kVp. With this, we can get a exact tissue density. So here you can, the exact tissue density, we can easily tell that how much areas are perfused, how much areas of non-perfused, easily we can do with the use of dual source CT. So dual source CT is very much available in our even government hospitals like Kilpauk Medical College have a dual energy CT. So with what is the usefulness of dual energy CT? So that since we are seeing that exact tissue density measurements, so you can differentiate from if you are having soft tissue densities, whether it is a soft calculus or a hard calculus as a gouty tophy or a calcified tophy, easily we can tell. And we can a little bit amount of contrast. Of the dose of IV contrast, we can finish the perfusion thing. So that's the advantage. So if in renal failure patients, you want to give minimal amount of contrast. So with you use the dual energy technique, easily we can do the thing. So this is the advancement can come to the our Chennai Government Hospital, and that is the photon counting CT. Already I told. So this is a improved spatial resolution. So it will be very useful for the temporal bone imaging and also other cardiac imaging. Everything the photon counting. So the final thing will be the photon counting CT. So coming to the next. So what is the techniques in CT? First, we will do the scanogram. Then we'll do the targeted tomography. And this is a scanogram. It's like a radiograph. So we will see this. We have to put next. We will do the axial sections from whichever area we want from head to toe, foot. We can put here. You can see the axial slides. Here, coming to the next cues more. So what are the indication of chest CT chest? You can answer. The diagnosis of pneumonia as a mediastinal disease evaluation, is a congenital abnormality evaluation, or you can say interstitial disease evaluation. I think most of us answered correctly. It's a diagnosis of pneumonia. So the CT is since already I told the CT is having so much of X-ray energy. So you don't use for the diagnosis of pneumonia. So the other disease, mediastinum, so you cannot see by radiograph, but you have to use the mediastinal evaluation. And sometimes congenital anomaly, most of the congenital anomalies, not only the bronchial abnormalities, they will also be associated with the vascular abnormality. You have to capture the both things. That's why you need to have the CT imaging for the congenital abnormality patient. And also you can see the interstitial lung disease well clearly seen in only by the CT scan. So diagnosis of pneumonia, it's not needed. So plain radiograph itself enough. Only the complications of pneumonia, then you have to use the CT. Okay. So if you're looking at IJ is leading the lateral board, and you can see that as in all that CT indications, so the congenital anomalies or a mediastinal mass, or the diffuse lung disease, the interstitial lung disease there, and there's the complication of pneumonia. Okay. So, and other than that, not only CT, taking, there are techniques also there. So just you cannot irradiate the patient, you cannot take ask the tech to do the axial sections or only during the inspiration or without giving any commands. Some of the childs are very brilliant. If you give the correct instruction, they will do the proper instruction, end inspiration, and also the end expiration. Sometimes this will be very useful. Here, in this case, if you are seeing there is some subtle hypo dense areas, while looking at the X-ray scan, we are seeing the air trappings are there. Okay. So this is how you are. So not all the patients need X-ray scan. Some specific patients will need the X-ray scan to tell the exact whether the bronchiolitis changes are there or not. So they has already told we can do the any coronal reconstruction or a sagittal reconstruction using the volume data in a CT scan. Okay. Coming to the next thing, you can do the not only a volume reconstruction, you can do the minimum reconstruction. You can classically you can see the tracheobronchial tree very clearly, and also the cystic lung disease is very clearly in this case. So you can use this kind of reconstruction algorithm to give the exact tracheobronchial tree anatomy, where there is a compression, narrowing, cystic is classically. And also you can see this kind of arterial reconstruction. Can see the inferior venous drainage into the intra-abdominal portions, and also you can see that from the aorta there is a abdominal vessel supplying the lungs also there. So these are all the things we can use for some complex anatomy. And this is how this is a virtual bronchoscopy. So virtual bronchoscopy, you can see you can go into the any bronchus, you can with the CT scan image itself. Okay. So coming to the next, all the measures of radiation reduction techniques except so multi-phase contrast study. and MR imaging for the mediastinum and lung. Or sometimes you can use the ultrasound Alara principle. What will be the answer? So answer is multiplicity. So why I am telling is, so multiplicity, we have to reduce the multiplicity. So if you are doing CT means, so we can do the only phase, we can do the in between arterial and venous phase. If you take the imaging, you can capture both artery and the venous phases. And you can see the parenchymal perfusion and everything. So you don't need to do arterial phase, venous phase, and delayed phase. So 3 times you are increasing the radiation. So as far as possible, you have to reduce the multiplicity, unless if you are specifically looking for some arterial feeders, a specific pre-surgical approach to the any congenital malformation, the arteries are arising from the aorta is there. So some specific indication only you have to do the arterial, venous like that. Otherwise, you can take a space between the arterial and the portal venous in between. That's one phase is more than enough. Okay. So Alara principle, as low as reasonably achievable. You can reduce the KVs, MS for the patients. Okay. So again, IJ is leading. So this is a normal basic CT. I can see looking at the first thing you have to look see the trachea, whether the trachea is fully. This is an inspirator scan. The trachea is fully distended or not. You have to look at any collapse. Based on this tracheal collapse or a fully distended, we can tell there is a inspirator scan or an expiratory scan, and you can see that we can go down. We can go down. We are going down, and we can see that. This is even this is the upper lobe. When you are coming down, you can see that between the upper lobe, there is a vessel-free zones are there. So that is the area fissure has to be there. And if you are started seeing the fissure, this is the major fissure which divides the lung into the upper lobe and the lower lobe. This is the lower lobe. This is the upper lobe. So you have to follow the trachea. You have to follow the trachea. So the trachea is divides into, there is the upper lobe bronchus, and this is the, even here you can see the left main bronchus, right main bronchus, upper lobe bronchus is arising. When you go one step below, so you can see the bronchus intermedius, and you can see that lower lobe left main bronchus is there. And one step, if you go downwards, this intermedius bronchus divides into middle lobe bronchus and the lower lobe bronchus. Here also divides into upper lobe bronchus and the lower lobe bronchus. You can follow the trachea into the bronchus, into the subsegment. And if you look at any alteration, the density is there, you can characterize the segment of the lesion, which segment is involved, which lobe is predominantly involved, like that. Okay, this is the lung window. So after seeing the lung window, so we are going to the we are seeing the base up to the base. After seeing the base, so we have to see the mediastinum. Okay, so mediastinum, whenever you are looking at the mediastinum, so you got to change the window. Here we can see the mediastinal vessels clearly and nodes clearly. If you are thinking about if you are wanted the node and the vessels, so best give the contrast. So when you are suspecting any infections, we have to see the nodes and all. So that's why. So any other mass lesion also, we have to look at the node. And also if you are suspecting mediastinum, you have to see the vessels and the node. So that's why we have to give the contrast in most of the cases. So when you are doing the contrast, we can abolish the plain CT scan. Okay, so only we can take the contrast study. So if you do the one phase single post contrast study, that is enough. You no need to do the plain CT or the contrast CT separately. Okay, that's a thing. So this is the mediastinum, this is upper and the middle, and you can see the lower aspect. So this is simply the mediastinum. We can see the prevascular space and the vascular space and this posterior spinal space. The 3 different categories there. If any pathologies, we can tell where is the prevascular, the vascular, or a paraspinal, paravertebral space. So with this, we can put what all the DDs can put. So contrast imaging CT is needed in all of the following except. You can answer now. Yes. So diffuse interstitial lung disease. So the plain CT that I told, the inspiratory and expiratory CT is more than enough. And you should not, only if you are suspecting vascular ring, septic emboli, and other disease only, mediastinal lymphadenopathy only, you need to have the contrast. So otherwise, so you don't need to, if we are the only HRCT, the interstitium is, you have to look at, that is CT, plain CT is enough. But rest of the conditions, you have to give the contrast. Okay. So Vignesh is leading. Okay. So coming to the basic patterns in radiology. So chest CT with a high attenuation, low attenuation, reticular pattern, and the nodular pattern. And distribution, we can have to tell whether the lung, whether it is in the interstitium or in the secondary pulmonary nodule. Okay. If we do the high attenuation, that is the consolidation, ground glass opacities, and mosaic patterns are there. And you can see that in the consolidation, so you can see that this is a consolidation. The consolidation is there. You can see that this is a consolidation. Consolidation means the opacity vessels not clearly seen. Everything is merged together. This is a consolidation. Okay. So the answer here is the alveolar proteinosis. And even the cryptogenic organic pneumonia, you will see the consolidation. The pulmonary edema, usually you will see the consolidation. Central peribronchial consolidation will be there. And also central hilar consolidation will be pulmonary edema is there. And we can see the other infection disorders, you will see the consolidations. Okay. Alveolar proteinosis, usually you will see the grassy paving appearance. Okay. You won't see the consolidation usually. Okay. Okay. Coming to next case. Next thing, this is the consolidation. See, this is you are not seeing the vessels clearly. This is a consolidation opacity. Here you can see the vessels and opacity. You are able to differentiate, but the lung tissue density is increased. So this is a ground glass opacity. This is a consolidation. This is a ground glass opacities. Okay. This is you have to do. But infection, both condition condition can present, and also even edema also you will have this kind of these things close together. Okay. So coming to the consolidation, cause of consolidation. So infective, eosinophilic, or a cryptogenic organizing pneumonia, pulmonary edema, and hemorrhages. And coming to the ground glass opacity, can be an acute or a chronic one. So acute, you will see the pulmonary edema, hemorrhage, pneumonia, eosinophilic pneumonia. And you can see the chronic one, hypersensitivity, organic pneumonia, is chronic eosinophilic pneumonia, fibrosis thing, the ground glass opacity. So coming to the septal thickening, so here what you are seeing, the reticular septal thickening. Whenever you see the septal thickening, whether the confining to the whether the interstitium is a bronchovascular interstitium or a centrilobar interstitium is involved, based on which we can tell the diagnosis. So you can see the septal thickening is a smooth thickening or a nodular thickening. Also, we can tell the diagnosis, and we can see the other case. You are looking at the mosaic attenuations. So mosaic attenuation, it's a thing to differentiate. So you can see in both small airway disease and the vascular disease. So which modality, which thing you have to do to differentiate the small airway disease, the pulmonary vascular disease. See here, the mosaic attenuation is there. So I want to rule out whether due to the vessel problem or a airway problem. So already I told you can inspiration and expiration technique. So if you do the inspiration and expiration technique, when there is a bronchial pathology, the air trapping will be increased inside. Whereas due to pulmonary arterial pathology, you won't see any significant changes. That's why you can differentiate. Okay. Okay. Coming to the next thing, this is a mosaic attenuation. This is a bronchiolitis. Everything appears the same. So we will see the mosaic attenuation. This is a case of the constrictive or obliterative bronchiolitis. I can see the pulmonary thromboembolism patient, we have the mosaic attenuation. Pulmonary hemorrhage also see the mosaic attenuations. So both will appear same. Only thing is you have to differentiate from the thing with the various other things like inspiration, expiration, the thrombus is there, everything you have to do it. Okay. So this is the air trapping in this case because the airs are trapped. So you will see the increased increased black densities in air trapping. Okay. See here the obliterative bronchiolitis. So what you are seeing is significant blackening of the okay. So because of the secondary any obliterative bronchiolitis, since there is a hypoxia is there, and the vessel also attenuated. See here the vessels are attenuated, and here the vessels are appears normal. This thing you have to keep in mind. So coming to the other spectrum, so low attenuation, it means it's more darkness. So until now we can discuss about more brightness. Here there is a more darkness. So you will see the emphysema, you will see the lung cyst, you can see the traction bronchiectasis and honeycombing. These are all comes to the low attenuation. So here you can see there is a large cystic lesion is there. Okay, large cystic lesion at the air pockets. So this happens to be the case of CPAM with all those things with the air fluid level. And we can see here, you can see the bronchiectasis in a different form, the cylindrical tubular bronchiectasis, varicose bronchiectasis, and cystic saccular bronchiectasis. So usually this cylindrical tubular usually seen in infection traction bronchiectasis, but varicose and the cystic saccular usually seen in the syndromic patients with bronchiectasis. And we have coming to this emphysema, we have to tell whether the emphysema is the paraseptal one or is the panacenar emphysema. According to this, we can put the diagnosis. Next, coming to the cues. So all of the following are cystic lung disease except see here there is a air-filled cystic and also there is a pneumothorax is there. Langerhans cells, lymphangioliomatosis, lymphocytic interstitial pneumonia, congenital lobar overinfection. So cystic lung disease. So is all those Langerhans, lymphangioliomatosis, LAM, and LIP usually seen in immunocompromised patient will have a cyst, whereas the congenital lobar overinflation just it's a expansion. This is not a cystic lung disease. Okay. Again, Vignesh leading the board. Coming to the next thing, you will see here there is a cystic lesions. If you see the bizarre cystic lesion, so there is a bizarre cystic lesion, and usually the costophrenic angles feed in this case, and this is a Langerhans histiocytosis. Whereas uniform cyst, say there is a uniform, and all over the lungs you will see the small cysts, and this is a lymphangioliomatosis. So usually lymphangiomatosis usually seen in tuberous sclerosis patient in pediatric patients. So in the HRCT, you can see the interstitial lung disease. You can see the reticular. You see there. See there is a reticular patterns. You can see the smooth or a thickened reticular pattern. With the based on this, there is a pulmonary edema or lymphangitis carcinoma. You can tell. Okay. So coming to the nodules we have to see whether the nodules in the either in the perilymphatic or a centrilobar nodules or in the randomly placed nodules. So we have to look at the randomly placed, centrilobar placed or a perilymphatic placed nodules. So if perilymphatic means most likely sarcoid LIP, that's a centrilobar nodules due to airway disease. If you see the randomly placed nodules, so the miliary nodules are there. Okay. Nodular patterns, you can see this is a miliary nodules. This miliary nodules are there, and you can see the tree bud nodules usually seen in the bronchiolitis patients. You can see that whether the tuberculous bronchiolitis or respiratory bronchiolitis, you will see these kind of classical tree bud nodules. That this is a tree bud we can see in most of the conditions. Coming to the next things. So when you are coming to the congenital malformations, so what is the role of CT? So you can tell the do the CT. You can tell whether there is a tracheal bud, the bronchial bud seen on the opposite side or not. Here only the bronchial bud is there. The rest of the thing is not visualized. Is the pulmonary hypogenesis, agenesis. See the agenesis. If you see the bronchus also, this is most likely to be a hypogenesis. Okay, this is how we can differentiate agenesis versus hypogenesis lung disease. Okay, and here you can see the lung. This is a volume reduction is there on the right side. In between, you will see the scimitar-like appearance. You can see the vessels are there. So it's a hypogenetic lung syndrome. Whenever you see the hypogenetic lung syndrome, you have to see the arterial and venous variations. So here the venous variation training into the IVC is there. That you have to clearly tell the treating thoracic surgeon when where we have to ligate and all. Okay. So agenesis, the aplasia, the hyperplasia. So that's why you have to look at. So agenesis, you won't see the bronchus. The aplasia, so rudimentary bronchus is there. Whereas the hyperplasia, you won't. You will see the everything, but everything in a reduced way. Okay. The agenesis, aplasia, and hyperplasia. Okay. So coming to the next quiz. All of the swelling. Hyperlucid lung except sequestration. The diagnosis is a sequestration. The sequestration usually you will see the consolidation like opacities, whereas the all the other pathologies like congenital lobar emphysema, scimitar syndrome, CPAM. Scimitar syndrome previously we have seen there is a lucency also there, and also you will see the opacity also you will get in a scimitar syndrome. CPAM you usually if you see the large expansion airplay level, you will see the lucency will be there. Sequestration, you will see the consolidation. Okay. Coming to the next case. So you can see there is a consolidation step. So whenever you see the consolidation in the left lung lower lobe, so you have to raise the possibility of sequestration. You can see there is a, what it means by sequestration, you have to see the aberrant arteries which is arising from the systemic vessels. Here the bronchial artery arising from the here you can see the aorta. So aorta from the feeding artery is supplying the. So this is we have to do we have to differentiate whether the intralobar sequestration or extralobar sequestration with the CT scan clearly. Okay. So here you can see the with the vascular thing, two vessels are supplying the lungs from arising from the aorta is there. Okay, clearly you are seeing the systemic artery arising the lung. Whether we have to tell whether the infradiaphragmatic sequestration or a supradiaphragmatic sequestration, that also we have to tell clearly. Okay. So coming to the lucent lesions. So lucent lesions, we can see there is a we see there is no cystic areas, but the lungs are hyperinflated. You are able to see the vessels in between the lucent lung. So this is called congenital lobar expansion. There is a hyperinflation syndrome, and the same kind of thing. If you are looking at this, the entire lungs appears to be loosened. There is a air trapping, more likely air trapping. So we have the differential diagnosis in this case. So what are all the differential diagnosis here in this case? So what are the differential diagnosis in this case? So in this case, if you are looking at this, so there is a soft tissue lesion is here. There is a soft tissue lesion. The densities, the fluid-like density. If we do the MR, so you can clearly see the cystic link. So the diagnosis here will be there. See, so as you're looking at this radiograph, this CT, we can tell more likely a congenital lobar hyperinflation. Here the diagnosis is due again the entire lung is overinflated due to the obstruction by the it's a branchial cyst. Okay, it's a branchial cyst causing obstruction and overinflation. And next patients we are seeing there is a narrowing is there. Tracheal narrowing is there. The tracheal narrowing, the right side tracheal, its indentation is there. Usually left side indentation is due to the left side aortic arch. So whenever you see the right side indentation, you have to think of right side aortic arch also. So if you in this case, so what you are seeing is this is a double aortic arch, both the right side and the left side. Right side is well developed. That's why you are getting the indentation over the right side of the trachea, and left side is a complete ring is there. So whenever the patient is having stridor or unexplained respiratory difficulties and recurrent infection is there, so you have to rule out any vascular ring like this case. So it can be a double aortic arch in this case. So you can see the double aortic arch clearly, and also other abnormalities, whether there is a subclavian laterally positioned subclavian artery compressing the trachea is there or not. Okay. So if you look at what is, we have seen the usefulness of the CT both in the congenital anomalies and also the infections. We have seen the usefulness of the CT. Now, and also tumor, as everybody knows that tumor, the CT is having more role. But here, if you're looking at the X-rays is near normal, except for the right paratracheal stripe is there. So we don't know the diagnosis, whether the sarcoidosis, whether the tuberculosis or not. So in this case, if it is this is sputum is negative in this patient, so and gene expert also negative. So what you have done is, if you subject the patient, since we are seeing the mediastinal pathology, so we are better, you can evaluate it with the CT scan. CT scan, what you are seeing, there is a consolidation and between but branching as well as opacities, and the nodules are there, and the ipsilateral hilar nodes are there. So confident diagnosis as the primary complex is made out by looking at this radiograph, looking at the CT scan. Okay. So, and also not only we can tell the thing, we can tell the density of the lesion. See, so you can see that the central areas, what the central area showing, there is a necrosis there. Here, central areas of necrosis there, hypodense areas. So confidently we can tell that the KC is necrosis in the central of the nodes. So most likely to be a chest tuberculosis. Okay. So we can I can see the here we can see the, if you look at where only we will see the consolidation, but here you can see the cavitation also. So our diagnosis is more certain in this case. So tuberculosis with the consolidation, cavitation. And also we can see this kind of patients and the patient with pneumatocysts. So we can see the thickening clearly, can see the air lucency here. So confident diagnosis. Okay. And also we can see there is a lucency, but the airflow levels are there. Lucency with the airflow levels are there. So confident diagnosis of septic emboli in this case. And also whenever you are looking at the patient with pneumonia, so patient with pneumonia suddenly develops hemoptysis. So we want to know what is happening in the lungs. So if you give the contrast, so what you are seeing, the space is filled up. So there is a septic emboli, the mycotic aneurysm of the right lung lower lobe. So confidently we can, in this patient, we can embolize the feeding vessels. We can prevent the mortality in these cases. Okay. This is a usefulness of the CD. So the single phase contrast CD is equivalent to the so if you get the one time CT is so equivalent to the 400 times of chest radiograph. That you have to know. So it means that if you are taking multi-slice CT in a patient, it's most likely to have 400 times of chest radiograph radiations. So for that, so you have to very careful in sending the patients for CT. It's most likely to be a complication of pneumonia or mediastinal pathology. So don't send for just like some patchy aspect opacity in the lung. So you have to and patient classical clinical presentation of pneumonia. So no need to confirm by doing CT. Okay. And if you're looking at the chest radiograph, the 0.02 millisievert on chest radiograph. Whereas if you do the chest CT is equal to 300 to 500 times, we can give the radiations. Okay. So this is everything is only the stochastic radiation. Stochastic means, so it's a 1 in 1 million examination chest radiograph can develop cancer. Whereas if the patient undergone CT chest, so 1 in 1,000 patient will go for cancer at a later stage. So this is a probability. It doesn't tell 100% all the patient will go for cancer. So that is, but the diagnostic with CT, we didn't, this what are the thing we are having is due to the Hiroshima Nagasaki nuclear explosion, the based on which only they have calculated the dose and all those things. But based on the diagnosticity, there is no clear-cut randomized control trial happened, how much patients are developed the cancer in the later stage. That's why, so we have to be very specific that limit our CTs to thing. But nowadays, the advent of latest scanners, there are many dose reduction technique. We can reduce the dose. We can reduce more than 90%. So only 10%. So it means 20 times of chest radiograph. So there are many things. So I am asking. So diagnosis here can, this is except, okay. Except means, so you should not do the multi-phase study. So you have to use the only single phase study, can reduce the dose by 1/3. If you are using the low kV technique, you can reduce the technique by again 1/3. You can reduce the 128 or higher CT with iterative reconstruction. You can reduce the dose by 1/3. So if you 30%, 30%, 30%, if you add the three principles in a single patient, you can reduce the dose by 90% of 90% you can reduce. That's why you have to specify low kV technique in the, most of the patient. So if you have a high slice capacities, so you can easily, you can do the iterative reconstruction. You can reduce the radiation dose to the patients. Okay. So before sending the patient, so we have to justify. Main goal is reducing the radiation dose, and you should only use the properly indicated. Consider the alternative. The patient is having pleural effusion, you can use the ultrasound. The patient is having the mass is a mediastinal mass, you can use the MR. Okay. So avoid pre-contrast or multi-phase scan. So only you can use the single phase, arterial phase and venous phase in between scan. So no need to do the organ shielding, the ovarian shielding or testis shielding. That is outdated. That will increase the radiation dose to the patient in different areas. So that's why, and also it will create artifact, and it, some of times the area under our interest also covered. If the ovary, if you are shielding the ovaries, ovarian pathologies are covered in abdominal things. So like that. So there is no selective organ shielding in radiography nowadays. Okay. So you can diagnostic image quality, yes, like you no need to have iPhone like clarity. You just have the small 5000 Android like image quality. That is more than enough to diagnose in more than 99% of patients. So diagnostic quality instead of the optimal image quality. So that is a thing in, I think there is ionizing radiation we are using. We have to be careful, and you know the correct indication for CT, and we know the limitation, and we have to use the multi-director CT. Then even multi-director, you have a higher thing, you reduce the thing, and also we'll do the all the isotropic, you can coronal, everything you can do with the multi-director CTs. So with this, I am concluding the CT chest thing. Next thing we will talk about the CT and MRI of the brain. Okay. So any doubts, sir?
Gopi,
Yes, sir.
I think you can finish it off, or it will be the same PPT, or it will be different.
Same PPT only is there, but I will go a little bit quickly, sir. Okay.
The same
within-
questions or Kahoot based?
Again, it's a Kahoot based only. I will go a little bit fast. Okay.
Yeah, because I think we should wind up by 10:30.
Okay. Okay. Okay, sir.
There are no questions in the chat box as of now,
Okay. Okay.
so you can proceed with the next one. Yeah.
Okay. Directly you can change the PIN number.
Okay.
312059. Okay, I'm starting now.
Yeah.
Yes, sir.
So coming to the neuroimaging in pediatrics. So neuroimaging, what we have the both, we have the MR, CTs and ultrasound is there. And we can see that, yes, previously I told the indication is very important. So you have to do the, find out what is the cause for problem, any illness. And also sometimes we have to do prior to the LP to rule out any hydrocephalus or increased intracranial ICP is there. Or the known cases, we have to do the follow-up the patient. Okay. And coming to the first question, the indications for CT in neuroimaging all are except CT scan. So to find out the calcification, so when there is MRI is not available, this is trauma or it's a epilepsy imaging. Except, okay. So diagnosis is a, whenever you see the epilepsy, say the imaging of choice is a MRI. So this we have to know that when you have to use the CT. The CT is using the trauma and there is a suspecting any intracranial calcification. When the MRI is not available at the time you can use it. The rest of the time imaging modality is the MR. That you have to keep in mind. Okay. So indication of, as I told, fractures and hemorrhages, non-accidental injuries like that, and the calcification. Here you can see the axial sections from base to the upper. You're going, so base, so you're going up, you're going up. So you are seeing the cisternal space clearly, and also the foramina magenti and the foramina plusca clearly, and going up, you are seeing the cisternal space, basal cisterns you are seeing. This is the brainstem, and you can see the frontal, inferior frontal, and inferior temporal, and this is the superior aspect of the cerebellum. Next, you are seeing there is a occipital lobe, the frontal lobe, the temporal lobes are there. You can see the ambient cistern, the contrigeminal cistern. This is the midbrain. This is the portion of the third ventricles are there. You have started seeing the basal ganglia, inferior aspect. When you go up, you can see the proper basal ganglia. This cut is very important. This is the basal ganglia. Here you can see the central aspect is the caudate. Here you can see the putamen is there. You can see the putamen areas. Here see the putamen areas. This end putamen, central globus pallidus, both together form a lentiform. You can see the internal capsule, hypodense areas. You can see the thalamus. So, okay, caudate, lentiform nucleus, and the thalamus. In between, you will see the internal capsule. Here you can see the either side of the caudate nucleus is the frontal horn of lateral ventricle. So opens in the third ventricle through the foramen of Monroe. Here is the caudate. Here the third ventricle. So this is the third. This is anterior portion of third ventricle, posterior portion of third ventricle. This is, you can see the pineal recess. You are seeing there is a pineal gland and the calcifications are there. And you can see the posterior aspect of the lateral ventricles are there. You can see the frontal lobe and the temporal lobe, the occipital lobes are there. And next you will see here, you can see the same areas in the external capsules, and we are seeing little bit, clearly seeing the ventricles, and you can see the ventricular body is there. Okay, next you have to find out the central sulcus. So anterior to the central sulcus is frontal. So you identify the T2 sequence. Is it A or B? So this is A, okay. So A only, that is a T2 weighted, since we are seeing the CSF bright, see this is the T2 weighted sequence. T2 weighted sequence, the CSF is bright. So ventricle also appears bright. So you can see the myelinated areas appears dark, whereas in T1 weighted sequence, the myelinated areas appears bright. So posterior internal capsule plix appears bright, and the ventral thalamus also appears bright. Okay, and this is the diffusion weighted sequence. So you may not be able to see the internal structure clearly, but it tells the important characters of the molecular diffusion. This is the SWA sequence. So you can see that vessels as a darker one. Any occlusion of the vessels or any hemorrhage. See here there is a hemorrhage, you can clearly see on the SWA imaging. This MR angiogram, this one is a MR spectroscopy. So MR spectroscopy, it will tell the molecule levels, biochemistry, whether the NAA levels at the 2 ppm and 3 ppm, we will see the creatinine peak. 3.2 ppm, we will see the choline peak. So, and the lactate peak, you will see the 1.3 ppm, we will see the lactate peaks. Okay. So indications of MRIs, so all the disease, unless it is contraindicated, so MR is the indication of choice. Only there is when they're suspecting any cortical fractures, MR may not see clearly. Okay. So if you're looking at this one in this, the strength of MRIs, all are except the no radiation. So cortical lining, soft tissue resolution, you can do the non-contrast perfusion angiogram. I want 100% answer of this case. So in this case, cortical. So as you know that MRI, the cortex doesn't have free flowing hydrogen atoms. That's why there is no MRI signal. MRI cortex, you may not see clearly in the MR. Okay, that's why in suspecting fracture, you have to do the CT scan in most of the patient. So non-contrast MRI techniques. So without contrast, we are doing the MRI. Okay. Here you can see the non-contrast MRI techniques, except so arterial spin labeling or MR angiogram or MR venogram or dynamic perfusion imaging, which is non-contrast except. So dynamic perfusion. So dynamic perfusion, you have to give the contrast. We have to chase the contrast. How the contrast is entering into the body, you can classically tell. The arterial spin labeling is a non-contrast perfusion technique. So MR angiogram, MR venogram also non-contrast one. So in this case, the patient with acute trauma with a sudden drop in GCS. So they were looking the CT scan. Since the injury is there, we are doing the CT scan. So here you can see that there is a fracture, and we are seeing the intracranial hemorrhage. There is intracranial hemorrhage, intraventricular hemorrhage clearly. So this you can tell that the patient is having, and also the sulcal spaces are obliterated. There is an intracranial hypertension is there. Can clearly tell that tell the emergency of this patient. So coming to the cues, so which of the following is not an extra-axial hemorrhage in this case? A. Okay. So we'll go. This is here the subpial hemorrhage is it's a intracranial hemorrhage. Okay, it's not it's not a it's a intraaxial hemorrhage. It's not an extraaxial hemorrhage. I will tell you explain. So if you're looking at this intracranial hemorrhage, so if, this is the intra parenchymal hemorrhage. So usually seen in injury and also AV aneurysm rupture, and this one is the subarachnoid hemorrhage. Subarachnoid space hemorrhage is there here. Okay. And next thing we'll see the subdural hemorrhage here. This is extradural hemorrhage. So extradural hemorrhage usually associated with the fracture and usually is a biconvex. That's a idli. The idli shaped hemorrhage in the extradural, whereas concavo-convex hemorrhage in the subdural. So subdural hemorrhage usually due to bridging vein ruptures. Okay. Here you can see the other type of hemorrhage is a subpial hemorrhage. The subpial hemorrhage, so usually seen in pediatrics, especially in infants and neonates. So you can see the subpial space are filled with hemorrhage because the subpial veins also it's compressed by the subpial hemorrhage. You can see the inside the brain, because of the venous occlusion, the inside the brain you will see the hemorrhage. So the two sides of the cortical mantle, you will see the hemorrhage. It's a classical of subpial hemorrhage. So usually seen in non-accidental injury in neonate patients. This have to keep in mind. Subpial hemorrhage, though always leaves with a scar. Okay. Patient will have gliosis. So which of the following needs immediate attention here? See two image, whether A or B. So whenever the patient comes to for any imaging, so you have to tell, we have to triage the patient, which patient needs for emergency care. So here the answer is, so you have to see the only one, that is the first case. So I will tell you here, this only I have presented. In this image, what you are seeing, base thing, very important. Base sections, if you see any emergency patient, you can triage the patient. So it means that there is a herniation is there or not. That is very important. You can see when there is a herniation is there, the cysternal space. So you can see that, and also foraminal space. Here the foraminus magenti and the lusca clearly seen. Here everything is obliterated. It means that there is a coning is there. This case had to give a more attention than this case. Here there is intracranial hemorrhage with a cerebellar herniation. So this you have to give more attention in this patient. Okay. So that is due to the herniations. So herniation could be a subfalcine herniation, or could be a uncal herniation, or could be a central herniation, or could be a tonsillar herniation. When there is a subfalcine, there is a large extradural hemorrhage, will produce subfalcine herniation. The ipsilateral ventricles compression will be there. Contralateral ventricle dilatation due to the foramen, opposite foramen membrane occlusions. Okay. So here you will see tonsillar herniation, tonsil peg-like extension into the foramen magnum. Here there is a subfalcine herniation, midline shift is there. Here you can see that this ipsilateral ventricle is compressed and contralateral ventricles are dilated. Okay. So coming to the infections, so this 5-year-old child with acute fever with encephalopathy, but by looking at the image, the asymmetrical involvement of the medial aspect of the temporal lobe, there is a hippocampus involvement, and also you can see there is a insular cortex involvement. The diagnosis in this case is HSV1. The inferior lobes are directly involved, either frontal or the temporal lobe. That is due to the proximity to the nasopharyngeal airway. That's why the how the HSV spreads. And here they can see the classical HSV, so bitemporal involvement is there. And you can see that sometimes you can go for hemorrhages also there. See that there is a hemorrhage, lot of hemorrhages in the HSV is there. And other viral disease in the Epstein-Barr virus, so basal ganglia involvement is there. So predominant deep gray matter. So other disease will have the predominant deep matter, varicella zoster, and the respiratory virus will have the predominant deep gray matter involvement. And brainstem involvement usually seen in, you can see the enterovirus and the rabies and the H1N1 and the herpes will have, herpes also sometimes will have the brainstem involvement, but characteristically seen in entero and the rabies infections. And we can see the predominant white matter involvement. You will see the paracovirus involvement and the rotavirus involvement. Cerebralitis, you will see the varicella zoster classically. If you see the myelitis also, you are think of enterovirus or a West Nile virus. If you are only the myelitis, you have to think in, if you see in the predominant dorsal pattern, you can think of varicella zoster. Okay. Coming to the quiz mode. So ring enhancing lesions. So whenever you're seeing the ring enhancing lesions, so what you have to think? Either hemorrhage, abscess, tuberculoma, or central pontile myelolysis. So except this is central pontile myelolysis. All the cases, subacute hemorrhages will show ring enhancement, tuberculoma will show ring enhancement, abscess will show ring enhancement. But only the central pontile myelolysis doesn't have a ring enhancement. Okay. So tuberculomas, NCCs, and abscess will have a ring enhancement. Only thing is, other thing will be the GBM also will sometimes will have a ring enhancement. Demyelination, subacute hemorrhage will have a thing. So whenever there is a ring enhancement, you have to look at the central aspect. The central aspect T2 dark means caseating granuloma in tuberculosis. That you have to keep in mind. Like this here, the central areas of dark. This is a caseating granuloma in the tuberculosis. So if you're looking at the NCC, so you can see, so this if you're looking at, very difficult to tell whether which one is tuberculosis, which one is NCC, everything have the ring enhancement. By looking at the T2-weighted imaging, the central areas having hyper intensity, it means fluid area. This is a NCC. The central aspect, here we can see the dark area, that is means caseating granuloma, that is a tuberculosis. So this is tuberculosis, this is NCC. This is how we can differentiate based on the T2-weighted imaging and also the, again, the diffusion rate, and also we can see the T1 contrast. So, but basically, if most of the time, if you look at the T2, you can differentiate whether NCC or a TB. Now here you can see that there is a lesions, very difficult to tell, but if you're looking at the other lesions, then the peripheral scolex is the NCC. But here there is a central hypodense lesions, the peripheral enhancement is there. Central aspect with the diffusion restriction is there. There's an abscess. Okay. So easily we can tell this thing. The diffusion restriction seen in all of the following except. So if you see here you can see the diffusion restriction is there. So you know that diffusion restriction, what all the condition will be positive? The infarct or the abscess or neurocysticercosis or exotoxicity, except what the diagnosis. So here the diagnosis is most of correctly told it's a neurocysticercosis. So neurocysticercosis won't have diffusion restriction. The rest of the things will have diffusion restriction. Okay. And you can say whenever you see the neurocysticercosis, sometimes the patient presents with acute hydrocephalus. At the time you have to think of anything in the ventricular system. Here the aqueduct is obstructed. You are seeing the ventricle dilatation is there. Okay. Sometimes the ring enhancement is there. And there is a diffusion restriction only the peripheral area. And looking at the SWA, there are multiple small hemorrhage. So this is classical of invasive fungal lesions. So this is the invasive fungal lesions. You will get in invasive aspergillosis. Or sometimes the fungal lesions can seen adjacent to the paranasal sinus. From here the other paranasal sinus involvement, even the everything is appears dark. The eye is also removed here, and you can see there is a extension into the inferior brain parenchyma, and classical trigeminal peak is there. So it's a fungal lesions. Okay, and we can see the ring enhancing lesion, larger pore is there, the P on pore appearance, basal ganglia like involvement, very classical in toxoplasmosis. Okay, and if you say the newborns, the peripheral ring enhancement, so larger cavitation, diffusion restriction is there, and this the abscess. So any group B infection, streptococcal infection or enterobacter, citrobacter, everything will produce this kind of abscess in the neonates. Okay, so you can see the diffusion restrictions here. Okay, coming to the other important thing, and if you see here plain, you are not seeing any significant abnormality, and only if you see the contrast, so everything is cysternal space are enhancing, so basal exudates. So whenever you see the basal exudates, so you have to think of either tuberculosis or a fungal lesion, or sometimes you get a sarcoidosis. But in our countries, most likely to be these kind of basal cysternal exudates due to the tuberculosis. And here you can see the not only brachymeningeal enhancement, you can see the leptomeningeal enhancement and the vascular narrowing in the case of tuberculosis. And sometimes you will see the infarct also. So whenever you see this kind of thing, so you have to do the vessel wall imaging to find out the vessels or arteritis is there or not in these cases. Okay. So pachymeningeal enhancement, if you see the pachymeningeal enhancement, what all the condition it will see, except see here there is a pachymeninges or enhancing. The pachymeningeal enhancement is there. So it is in what are the conditions? There is a tuberculosis, post lumbar puncture, idiopathic intracranial hypotension or hypertension. So the diagnosis is a hypertension. So it's classically seen in intracranial hypotension or a tuberculosis or a post lumbar puncture, but it won't seen on intracranial hypertension. Okay. Okay. So pachymeningitis, so tuberculosis, inflammation, post lumbar puncture, and hemodialysis, all those things you will have the pachymeningitis. Next thing we will see the recurrent meningitis, the recurrent abscess formation. So here there is a diffusion restriction, abscess is there. So everywhere there is an enhancement is there. So whenever you see the recurrent meningitis, so what are the condition you will see? Okay. So either spinal dystrophism or a congenital abnormalities, or could be the CSF rhinorrhea. So whenever you see the recurrent meningitis, you have to see certain areas. These are normal or not. So here the diagnosis, all the condition you have to look at. So spinal dystrophism means so dorsal dermal sinus. So dorsal dermal sinus is an open one. So you will see that here the dorsal dermal sinus is an open one. From here the infection entered, it will gone into the spinal cavity. From the spinal cavity, the entire cord involved and also extending into the brain. Yeah, okay. And also if looking at this area, the dorsal spinus is there. And you can see that the inner ear malformation, cystic cavitation of the inner ear is there. So that is a case of likely case of infections. Okay, these things, recurrent meningitis, recurrent abscess, you have to rule out all those things. Like this here, you can see there is a defect CSF rhinorrhea, you have to find out. Okay, coming to the next thing. So white matter changes in all of the following except see. So the diagnosis here will be the neuronal cerebral lipofuscinosis. So all the rest, all of the condition, you will see the neuromyelitis optica, HLH, you will see the MOGAD, you will see the white matter changes, and you can see that this is what we are dealing with. This case is neuroinflammation. So the neuroinflammation, you will see both the basal ganglia, the thalamus, everything is involved, and the subcortical lesions also involved in the case of ADAM. And what are the other types? You can see the MOGAD, NMO, and the MS, and the HLS is there. So if you see the MOGAD, you will see both the brain and the spine and the optic nerves are involved in MOGAD. So MOGAD, you can see the peri-orbital fluffy enhancement is there. They're very classical of in MOGAD. the subcortical involvement and the brain involvement, basal ganglia involvements are there. Whereas the other disease like NMO spectrum disorders, so NMO, you will see the periaqueductal gray matter involvement is there in NMO spectrum disorder. Here you can see the periaqueductal, periventricular involvement is there in NMO spectrum disorder. Whereas NMO spectrum disorder, if you're looking at the optic nerve, you can see the chiasma posterior portion is involved in NMO spectrum disorders, whereas in MOGAD, anterior aspect is involved. MOGAD, anterior aspect is of the optic nerve is involved. So this is how you can differentiate. Other demyelination is a multiple sclerosis. You can see the linear hyperintensity. Okay, linear hyperintensity in multiple sclerosis. On the cortical, after the fever, patient developed this kind of temporal lobe involvement with classical psychiatric symptoms. You can think of NMDR related encephalitis. Here you can see a non-specific white matter changes, patchy enhancement in a clinical settings. Reticulocytes count is elevated, other inflammatory markers also elevated. So if you think of HLH, the hemophagocytic lymphohistiocytosis. So coming to the next cues, so infection triggered encephalopathy syndrome, except, okay, so ENEC or MOGAD, AEST or MERS. So infection triggered encephalopathy syndrome, except I am asking, okay. So the diagnosis here will be the MOGAD, but rest of all the things are it's on the infection triggered syndromes. So infection triggered encephalopathy syndrome. So what are the things? The ENEC, the bithalamic lesions. So bithalamic lesions are there. There is a hemorrhage also there, very classical in ENEC. And you can see the fever with encephalopathy and diffusion restriction, classical claustrum involved in the fires lesions. And we can see that this is a diffusion restriction after a week of presentations. That is a fruit tree-like appearance, bright tree-like appearance in the case of AESD or Aleret disease. And you can see here, can see only the splenium is involved, rest of the brain is normal. That is the reversible splenial lesions. All this constitute to the ITS. Okay, this all constitute the ITS. Okay, so again, if you see this kind of diffusion restriction along with the basal ganglia involvement is a hypoxia or anoxic disorders. So hypoxia, this is very important. So, and this one, this is very important. Everyone has to know. This is a diffusion restriction in a territorial lesions. So arterial territorial, this is a MCA infarct. So whenever you see the diffusion, you have to do the ADC also, whether the dark is present or not. So this is a infarct, you have to be in mind. So we have seen the infarct, we have seen the venous infarct, the venous veins are clogged with a thrombosis there. Okay, so venous infarct. I think this is a deep venous infarct. So coming to the MR spectroscopy, so this is the MR spectroscopy. So it can be used for most of the conditions, the metabolic disorders, or the tumor evaluation, or a developmental delay, but it is not used for the congenital malformations. So if you're looking at this one, so metabolic disorders, we can, in metabolic disorders, imaging is very important. If you do in early stage, subclinical, everything will be normal. If you do the late stage, all the disease will be burnt out. Everybody will have the atrophy. You cannot give any meaningful diagnosis by imaging. So the only specific period of a time, the classical finding will be there. At that time, you have to capture the MR imaging finding. So that time only it's still the classical imaging finding. See here, you can see we have to tell whether the gray matter is only involved or a white matter only involved or gray and white matter involved. So with this, we can tell the diagnosis. So, okay. So only gray matter involved. So basically methylmalonic aciduria, the urea cycle disorders, and you can see the mitochondrial disorders you can think of. Whereas the white matter only involved, we can think of okay, in this only gray matter environment, you have to see the classical presentation like a battening-like appearance in a case of glutaric aciduria, and you can see this kind of classical involvement in propionic acidemia. And white matter leukodystrophy, we have to tell whether there is a frontal involvement, the parieto-occipital involvement, the subcortical involvement, the periventricular involvement. We have to tell, and you can tell this a frontal involvement usually seen in Alexander type of disease, Alexander disease. And here, if you see the Alexander disease, you will see the enhancement will be there. And you can see you have to tell whether there are cavitation white matter changes are there. Is there other differential diagnosis? If you see the posterior involvement classical in the along the periventricular region, you have to tell this X-linked adrenoleukodystrophy in this case. See the classically you can see the posterior involvement with skin pigmentation in a X-linked adrenoleukodystrophy. The subcortical involvement classically is seen in L2-hydroxyglutaric aciduria and Kearns-Sayre's disease. Whereas this is how the MRS usually in most of the condition, the specific peak, the NAA peak in some conditions we can see. So you can see that you can see in this case. So what in this case you see the Canavan peak is NAA peak is so much there. Rest of the peaks are reduced in the case of Canavan's disease. So this is a Canavan's disease. So much NAA peak is there. So rest of the peaks are not seen. This you have to identify. See this is a gray matter and the white matter is involved. Na is elevated. This is the only some of the disease can't really tell with the MR spectroscopy itself. The diagnosis we can other disease like creatinine deficiency you can tell by looking at the spectroscopy. If you're looking at this kind of vessels or tortuous, you can think of Menkes kinky disease or calcification is there. We can give the Cockayne syndrome, and also Milas also will have the calcifications. And whenever you see the brain, don't stop with the brain. So spinal cord is a continuation of the brain. So whenever there is any abnormalities in the brain, it's supposed to be continuous over the spinal cord. So you have to screen in most of the cases those showing MR brain abnormalities. Okay. So here, if you see prominent lactate peak in any conditions, you have to think of mitochondrial disorders. So there are many mitochondrial disorders are there. Just you have to remember, if you see the lactate peak at 1.3 ppm, you have to think of mitochondrial disorders. See, there is a diffusion restriction like infarct, not confining to any territory, and there is a peaks, vessels are normal, and this is a case of Milas. The thing is, whenever looking at the white matter changes, the classical spectrum is there. Do the specific imaging and confirm. Whenever you are not seeing the classical MR spectrum or see some kind of lesions, you have to do the other expert opinion or ways. Then you could do all those things to confirm the diagnosis. So epilepsy, you have to look at the hippocampus carefully for any hippocampus or a cortical malformation is there or not. So tumors, whenever patient present with any sudden hydrocephalus, so you have to rule out any tumors is present or not, as in this case. Okay, in this case happens to be the medulloblastoma. Okay. Okay. So hemiparesis, this is very important. This slide I want to touch upon very, especially for the pediatrician. So if you're looking at the not only white matter changes, so by looking at what is the diagnosis in this case, here the diagnosis is this is the clue. So this is the clue. This is the clue. This is the reason for the white matter change here. So here this is the case of the non-accidental injury or a battered baby syndrome. So here whenever you see the subdural hemorrhage, so you have to raise the possibility of non-accidental injury. That is very important. So here you can see the white matter changes also there. So if you see this case by looking at the radiograph, so a lot of you will see the fractures are there. It's a non-accidental injury. This you have to keep in mind. Sometimes you will see these images like this. These are all due to the edema, congestion. You don't give diagnosis as subarachnoid hemorrhages in this case. So take home message. The main thing, whenever looking at the CT, first read at the base. So whether that's why you can differentiate whether the emergency patient, whether having herniation or not. And looking at this MR, any lesions, we can find out whether the white matter pathology or a gray matter pathology. Here there is a gray matter pathology, anoxia. Here there is a white matter is involved in a case of allergic conditions. So with this, we can tell a meaningful diagnosis in any of the patients. Thank you for giving me this opportunity.
Thank you, sir. Thank you, sir. Thank you for that very informative and not only about the basics and the nuances of reading CT and MRI, but also about some of the common conditions which we come across in our practice, and also about the radiation exposure. Because as pediatricians, we are bothered about whenever we order for a CT, we are a bit apprehensive about the radiation exposure. They have touched upon that also, and for making the session more interactive, online session you have made more interactive with your Kahoot platform. So the topic is open for discussion. I don't see any questions in the chat box. Any questions from the audience?
The main thing, don't over exaggerate the CT radiation, but the latest thing, we can reduce the radiation by 90%. That is
Yes,
the
sir.
message I want to give.
Okay, sir. Thank you. Thank you so much.
Please put the final result. Kakoots.
Yeah, I will tell you, sir. I will tell you. I'll tell you. Okay, sir.
Please first.
Okay, sir. Okay, sir. Thank you, sir. Thank you, sir. I think I will.
If there are no further questions from
First
the
session only we have got Vignesh is got the first prize. Here we can see the IJ. Who is IJ? IJ, sir.
Congratulations, sir.
IJ Vignesh SK. Who is IJ, sir?
EJ.
IJ.
I was there.
Manoj IJ. Manoj IJ. I could see the name as Manoj IJ, sir.
Okay.
Manoj IJ. Sir.
Yeah, he's a pediatrician or a radiologist. Manoj is there actually.
Manoj, we can text. Manoj, you won the prize?
Yeah, Manoj
he's
is
a pediatrician from
Bangalore.
Okay.
Congrats to you, Dr. Manoj. Yeah.
Okay, sir. Okay.
Congratulations.
I think this is the first time we are doing. There are some little bit time lag is there. Next time we will concise what all the things. I think this will be the thing for the future. Future will be like this. We have to be more interactive. Okay, sir.
Okay, sir.
Thank you.
Okay, sir. Okay,
Super.
Thank you.
The problem, we are all non-radiologists. All the questions are except. So the time frame is very important. The thinking capacity is more.
Yes, sir.
Hope you understand my answer, sir.
Yes, sir. Understand, sir. Understood, sir. Clearly understood. This is the first time we are doing the online quiz. I think hopefully next time we will take over all the concerns, sir. We will frame the question according to that.
Excellent.
Okay,
Here
sir.
the question framing is very important than a question. That is, answer framing is very important. The choice is very important than a question.
Usually it is difficult to answer except questions.
Yes, sir. That we have to be very careful regarding
PG entrance questions.
Anyway, that was more interactive, sir. Because offline classes can be, you can see the audience and the delegates and talk, and online you have to sit in all alone in a room and talk to a virtual crowd. So you made it more interactive. Thank you.
Okay. Thank you, sir. Thank you.
Yeah.
Thank you, Dr. Gopinath and Dr. Ramasubramaniam.
Yeah. Yes, sir.
Okay.
Yeah. So,
Thank you, sir.
Dr. Sripriya, can you
Yeah.
propose what you
Summarization, I'll
thank
do it
and then
later in our
summary?
group,
Yeah,
sir.
yeah, that can be done. Yeah, you can
Gopinath sir,
thank
can you
everyone.
please
Yeah.
stop share, sir? Thank you.
Yeah, Sripriya, you can unmute and you can wind up this session. Yeah.
Yeah, you can wind up the session. Shri Priya.
Thanks a lot to Gopinath sir for clearly explaining the concepts of both um, uh, for the audience, of the CT for the audience. And the interactive session also was very nice, kept all the audience to interact very in a lively manner. Thank you so much, sir. And thanks to Ramasubramaniam sir for moderating.
Thank you.
Thank you all for joining.
Thank you very much. Thank you, Dr. Gopi, Dr. Rams, and all those still who are waiting at
Okay.
10:45 to
Good
hear
night.
this
Thank you and
marathon
good
Good
degree
night.
skills. Thank you, madam. Thank you.
Thank
Thank you all.
night.